start the meeting.
All right, I will call roll. I'll start with you, Commissioner Chung,
Present.
Commissioner Chow,
Present.
and Commissioner Guillermo on the phone.
Present.
Okay, great. Thank you.
And it is my turn, I think, to acknowledge the Ohlone land. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never been ceded, lost, nor forgotten their responsibility as the caretakers of this place, as well as for all people who reside in their traditional territories. As guests, we recognize that we benefit from living and working on their traditional homeland, and we wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community, and by affirming their sovereign rights as First Peoples.
Thank you, Commissioner. Item 2 is the approval of the September 7th, 2021 committee minutes.
I move approval.
And I think Commissioner Guillermo might
I'll second.
Okay.
Yeah.
All right.
I'll second.
Okay, we'll do the roll call vote. Mark, do we have public comment?
Oh, I'm sorry. I was just talking and I was muting myself. Folks on the line, if you would like to make comment on item 2, the minutes, please press *3 to raise your hand. All right, no hands, commissioners. So I'll do a roll call vote. Commissioner Guillermo?
Yes.
Thank you. Commissioner Chow?
Yes.
And Commissioner Chung?
Yes.
All right, great. Thank you. And let's go to item 3, monthly contracts report, and welcome Ms. Ruggles.
Afternoon, everyone. Thank you. Sorry, I'm probably the only one that can't use a WebEx a year and a half into COVID. Sorry. Okay, so the first contract on the contracts report today is the first of 2 of the San Francisco Public Health Foundation. The first contract we are bringing to you today because since the time that we brought it back last time, there's additional funding being added, and we want to grab all the funding and maximize the term because we are taking it to the Board of Supervisors. And we had planned to go to the board right after the last time we came to the Health Commission, but we weren't able to. That was back in March 2020. So here we are today. This reflects the increase, that reflects the funding that was added, and then adds that funding through the end of the term. This, the role that the San Francisco Public Health Foundation plays administration for the subcontractors, and then like funding the evaluation and all of that, coordinating on behalf of the department. But as I'm stumbling through this, Patricia Irwin is here, who's the Deputy Director of CHEP, if you have questions about this contract. But I'll just add, and you might not have even seen it because you just may have received it, but Commissioner Chow sent us a series of questions, and the response is included. But within this contract, there is an evaluation vendor, Ramey and Associates. And so there's actually a very complex and elaborate set of objectives and what they're looking at to be measuring. And so this vendor's helping to do that. And well, anyway, okay. And then separately, there's a Sugary Drink Distributor Tax Advisory Committee, and they actually report to the board and the mayor annually of an evaluation related to sugary drink tax usage in this project. So it's really just standard. It hasn't been that long since you've seen it, but I believe Patricia's here if you do have programmatic questions that weren't clear or you want to know more beyond what's in the report.
Let's see. I'm unmuting Commissioner Guillermo. Any questions from you, Commissioner Guillermo?
None for me, thank you.
Okay, great. Any other commissioner questions?
No, Commissioner Chow, do you have any additional questions for this?
Yeah, no, I'm happy to hear that there is a contractor who will actually be evaluating this because it seemed to me just having staff to do it was kind of a daunting challenge, which is true about the two contracts that they manage. So thank you very much.
Okay. Thank you.
Okay, the second contract with the San Francisco Public Health Foundation is for COVID and non-COVID contract management services. This, again, is, I think we brought this back to you before. This time, we're also going to the Board of Supervisors, and we received more funding. And so we're maximizing, again, the amount of funding, expanding the contract to include all the funding, which requires Board of Supervisors approval. So here we are today with this contract. We haven't extended the term, but we have added funding. One of the questions was, what exactly are we doing for the COVID portion of the funding? And so again, that's in your document that we sent over, but essentially what we're funding is a process for community organizations to provide COVID-19 outreach, testing support, and wraparound support for COVID-19 positive people. There's also continuing funding for training of community-based care investigation and contact tracing. So more COVID response, but again, Patricia Irwin, Deputy Director of CHEP, I believe, is here. If there's more questions, it's pretty broken down in that document about how the funding is being spent. But you have more questions.
Let's see, Commissioner Guillermo, anything from you?
Yes, I actually did. Given the expansion or the provision of vaccinations that are going to be now focused on students through those SFUSD sites, will these funds be part of doing the outreach around that, or is that separate?
Hello, Commissioner. Michelle, should I answer that?
Yeah, please, please.
Okay, great. These contractors are actually definitely supporting vaccine events. There's 9 priority neighborhoods where the COVID cases are the highest. As there's alignment with the events at the school district sites as well, in those neighborhoods, they will be part of that. There may be some additional resources supporting the Unified School District vaccine event sites as well.
And Patricia and everyone, when you all speak, especially because there's a commissioner off camera, could you say your name and your title or where you're from so that there's context?
Yes, thank you. I'll do that going forward. Patricia Irwin, Deputy Director, CHEP Branch. Thank you.
Any other questions?
Okay, thank you.
All right, it looks like it's okay to move on, Ms. Ruggles. Again, thanks a lot, Patricia. Michelle, I believe you're muted.
Okay, I'm back. The third contract today is with the Regents of University of California for the Alliance Health Project. And this, like several contracts that we've been bringing to you over the last couple of months, is because we were unable to complete all the way through the end solicitation that impacted a whole handful of contracts. So this, like the other contracts, has been put into a 1-year contract using sole source 2142 sole source, which allows us time to complete a solicitation. And then once the solicitation is done, then we'll do new contracts for whoever was successful, and onward we will go. But so this is a placeholder to ensure the continuation of these services during this gap period. So there really isn't too much of a change except funding to add the, to pay for the year. But it is retroactive to July 1st, and essentially it's just timing. We have actually just filled 2 vacancies in that contracting unit, so that should help. But that's why it's retroactive to July 1st. And then there was a few questions, and those were included in the handout that answered the questions. I think I'll defer to Hannah, and I don't to answer the first one if you want to go over that. And then I answered why the contract was retroactive and explained its ongoing services put into a new contract. But Hannah is our HIV behavioral health coordinator under CHEP. Do you want to talk about the demographic question?
I can do that. Yes. Hi, good afternoon, commissioners. And this information was provided by Lori Temis, who is the director of Alliance Health Project. And I think Lori's on here in case there's additional information needed. So what it means is that the demographics of the subpopulations that did test positive for HIV are different from the subpopulations for people who inject drugs. Versus men who have sex with men. And so Lori provided that table for you that splits out the data from 2020 that shows that for men who have sex with men, the demographic breakdown for HIV positive results are different compared to people who inject drugs. So if you have further clarification, please let us know. And then Lori, if you want to add anything, please go ahead.
Thanks, Hannah. I'm Lori Temis, the director of the Alliance Health Project. I don't have anything to add necessarily, although it may be that the language in that sentence is not elegant and it's therefore confusing. So that's something to just acknowledge if that's the case, but hopefully it was clarifying by that.
And so I had asked that question, and I think the question comes really, is there a difference with what we are going to be doing, although the demographics are different, and thank you for the explanation that we're talking about, but would the services be the same?
I think materially the services are the same, though, for example, we may be more successful at doing HIV testing on folks who inject drugs when we do our mobile testing as opposed to our on-site testing. And that just may be that, that has to do with the location and decisions we might make about what might be a good location to do some outreach. We have resumed testing, but we haven't actually resumed our mobile testing yet. So I know that there's secondary to COVID. So we're still sort of working on that, but there isn't sort of material difference, though. As I said, there could be decisions about how to engage folks that are slightly different.
Thank you. I have no further questions.
Thank you, Dr. Chow. And I think we can move on to the next contract, and good to see you, Laurie.
Okay, so the last contract on the contracts report is called Dataway US. This is the approval of a new contract, but it's actually continuing services. So you saw the last contract in October 2020. Checkpoint software is critical to the data security of DPH. The way this was selected is through a sourcing event, which means that the lowest bidder bids on the lowest bidder is the winner. And there's no other qualifications. It's just what is your bid? And because of that, there's no contingency because the price isn't going to change because you bid and that's what the cost is. And so that's why there's no contingency, which was one of the questions, because we wouldn't be adding anything to the cost. So one of the questions was how has their performance been in the past and what slight changes occurred? because in the report, it talks about there's a 7.43% increase in the annual amount. And so what happened? And so Mark Upchurch, our Chief Information Security Officer, provided this response, and I believe he's also here, and it's in your handout, but it was the increase is the cost that was associated with DPH adopting and implementing some new technology that transitioned their gateway firewall software onto DPH's legacy hardware. And so I guess I feel like I'm speaking another language. I should probably just let Mark Upchurch say it, but that, so essentially though, it's the cost of the new firewall appliance and the implementation. So if you have specific technological questions, I believe Mark Upchurch is here.
Yes, so good afternoon, Commissioners. This is Mark Upchurch, Chief Information Security Officer for the Security Operations Team for DPH. And to summarize, the slight increase in cost, the 7.4%, is related to a transition to newer, more modern technology. It transitions us from running the software on older legacy DPH supported and administered hardware to an appliance that Checkpoint Dataway is now responsible for maintaining and maintaining the hardware as well as operational readiness of the software.
Any questions?
Any questions?
Yeah, Commissioners, I'm unmuting you, Commissioner Guillermo. Any questions from you?
Yeah, just one quick question. Then that the cost of that bridge piece of technology, who owns that then? Is it DPH or is it the Dataway vendor?
So that is a CapEx expenditure, and we now own that appliance.
Okay, thank you.
Thank you.
Any other questions, Commissioners?
No, just a comment. Thank you, Commissioner Guillermo, for asking that questions. I think that with like how sensitive data security these days are, and what transpired yesterday, I think that these are the investment that we would expect to see increase as well in the future. Dr. Chow?
My question actually is more related to because I'm accepting and certainly we need to have this type of service. How often actually do we use the sourcing event process, and how do we determine that we're going to use that as versus a regular RFP or any other mechanism for soliciting contractors?
From Michelle on the contracts side, I'll get back to you. I didn't actually know what it was. So I think it happens, maybe Mark, if that happens more often on the IT side, it's not a typical process.
So last year, it was an annual renewal based on the long-term. So let me give you some background so this answer will make more sense. So it's not like your typical software. It's not like we install it on one server. There are several components to this, and this solution, it basically has multiple layers and multiple tiers. And so when we talk about installing this software, it really was a 1.5 to 2 year project, because you're building the firewalls, you're building the rules, you're installing protection on every endpoint across all of the DPH. And so while we may change the OEM, we most likely, unless there was some catastrophic event, would not change the checkpoint component, which is the actual service that we're getting. And so because of the amount of effort it takes to do the RFP and to finalize the contract, this year we decided to go for a 3-year period. Last year it was 1 year. Prior to that, I was not with DPH, but I know we've been using the checkpoint solution, for at least 5 years. But I think to answer your question, it's possible that we go to bid and find another provider other than Dataway. It's just that they've consistently provided the lowest bid and the highest value.
So, no, I thank you for that explanation, Mark. And I'm wondering, not asking for right now, but if Michelle would give us a context in which a sourcing event is different from a decision that maybe this is, maybe it is, and maybe it isn't sole source, and maybe that's why you do that as versus doing an RFP. I think there was good rationale not to necessarily do an RFP. But I'm just kind of curious, not about this contract, but about when we might apply a sourcing event. It could be that in the future, somebody thinks that a particular provider is really great, and we would just see if they're going to be the lowest price, and that's somewhat different than going through the whole complexity of the RFP. So just want to know kind of how one determines which type of contract to have. And you needn't respond today, but I think it's a general question about understanding the different types of solicitation that we have.
Dr. Child raised a really good questions, actually, because I think that DPH does use a lot of different types of proprietary softwares. And a lot of times because of that, it's difficult for us, to change vendors. It's not necessarily the only one that provide, software that have similar functions. So I think that, it's really a matter of, how do we get ourselves out of being trapped into this kind of only one vendor situations, and to really make it fair for, if there are local vendors who actually can perform similar functions, and, and why we are not using them. Is it just because of the proprietary nature of these software?
No, I appreciate that, and I just am looking to see what the logic is in terms of because I think this certainly would be a lot less work, and doesn't apply to other things that we should be doing in terms of using this type of mechanism rather than going through a whole RFP for even times that we know that there's really only going to be 1 or 2 contractors that are going to apply. And it's sort of outside of this IT that I'm thinking of, for example, certain mental health services that we render, and we seem to, put out an RFP all the time. Wouldn't it be easier just to put out a cost thing, because this is what we're intending to do? But so it's more a decision-making question.
I'll get more information. I comment on that, but I'll get better. But I did get an email back from Rob Longatano in the contracts office. He said that's the only one that we've done. And he said the idea he wrote, the idea being that what we are looking for is basically sold by a reseller, and it's cost-based. So we want this thing, how much is it? But yes, I'll explore that question though with the other contract staff and let you know.
Yeah, it might be a process that we all find will be helpful for everybody. So thank you.
All right, Commissioners, I'm going to quickly go to the line to see if there's any public comment, because we're at the end of the report. Folks on the line, please let me know if you'd like to to say something about the contracts report, item 3, by raising your hand. Press *3. *3 to raise your hand. Okay, no hands, Commissioners. So unless you have more questions about the contracts report, this would be an appropriate time to make a motion.
So moved that we recommend the contract report to the full commission.
I'll second.
Great. I'll do a roll call vote. Commissioner Guillermo?
Yes.
Thank you. Commissioner Chow?
Yes.
And Commissioner Chung? Commissioner Chung, you're muted. Oh, sorry.
So yes, I was giving a monologue. Yes, and we'll add that to the consent calendar.
Okay, great. Thank you, everyone who participated. Item 4 is a request for approval of a new contract with Cross Country Healthcare. And I believe there's the 4, 5, and 6 are related because I believe they're all similar services. And Terry D'Antoni, I believe, is going to be reviewing this.
Correct.
Good afternoon, Mark and Commissioners. Thank you for having me today. We do have all 3 contracts, and we have submitted them in the past, but in the past we have submitted them along with the RN contracts. So this is purely ancillary to separate the RNs from the PCAs and the CNAs and medical assistants. So we would have a better tracking mechanism for our RNs. This will also, the funds a little bit up because some centers like Laguna Honda uses more of the ancillary than Zuckerberg. And with COVID coming up now, it's very difficult for us to get any sort of registry or traveler help without increasing the rates. And so we have COVID rates and non-COVID rates in all 3 contracts.
So Commissioner Chung, with your approval, may I ask the public to comment on 4, 5, and 6? They can do it separately, but okay, great. Folks on the line, you're able to make public comment on items 4, 5, and 6 at this time, and you can make 3 separate comments if you'd like. Just let us know by pressing *3 to raise your hand. *3. All right, I see no hands. So any comments from you, Commissioners? Commissioner Guillermo, I've unmuted you.
Thank you. I have no questions. I just think this is an important thing for us to have in place, given the shortage of labor, you know, not just COVID related, but that is to come as things just sort of come a little bit undone in the healthcare labor market. Thank you.
Thank you, Commissioner. Other commissioners, any questions or comments?
Yeah, I did find the little hand, but that's okay. My question coming off of Ms. D'Antoni's very good explanation is, how do we distinguish that we're hiring them for COVID and or non-COVID?
So in the past, what we've been, thank you, Commissioner, it's a great question. If we have, we don't have a lot right now. We have about 14 COVID patients in the house right now. We've been averaging 14 to 20 in the last 3 or 4 weeks. So right now our need is not more for COVID, it's more for our regular workforce because we have people that are out because of vaccines and whatnot. So our workforce has dwindled, and so we would see if we could get where we could get our ancillary staff. It may be because of COVID that we can't get anybody because people are being deployed. So we may have to use it that way. We just needed the wiggle room so that we could get the ancillary support when we needed it, especially at Laguna Honda, where that's the primary workforce for them. And just to add that cross country is our highest, and we use them the most, and we have backup 1 and 2 as well. So we just wanted to make sure we had ample supply in order to meet our patient needs, our contractual needs with our staff, and our yes.
So would it be that if you are hiring in order to help assist in COVID patients, or is it related, as you say, to potentially a shortage even on non-COVID patients because of the COVID? I mean, is that a determination made between you and the companies to come to a mutual understanding of who you're trying to hire? Or do you sort of determine this is a non-COVID slot versus a COVID slot?
Yeah, right now I believe it would all be COVID because of what's going on with the workforce related to COVID. And we would make those terms. We would always go for non-COVID first if we could. That's, you know, but because of the workforce issues, and those are not artificial, those are related to COVID, we probably would have to go with the COVID rates.
Okay, no, thank you.
Thank you.
All right, so commissioners, even though you all discussed and Ms. Antoni presented the contracts as 3, you all need to vote on each item because they're on the agenda that way. So if you would consider motions to start with item 4 and vote on that and then go to 5 and 6.
I move to recommend the new contract with Cross Country Healthcare.
Great.
I'll second.
Thank you. I'll do a roll call vote. Commissioner Guillermo,
Yes.
Commissioner Chow,
Yes.
and Commissioner Chung.
Yes.
Great. So that's item 4, the cross-country stuff.
Thank you, commissioners.
So
I move similarly for a recommendation on Maxim Healthcare Staffing Services to the full commission.
which is item 5.
And I will second that.
All right, I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Guillermo,
Yes.
and Commissioner Chung.
Yes.
All right, great, thank you. And then item 6.
Yes, I would then move for the recommendation to the commission for approval of the supplemental healthcare services contract.
And I'll second that as well.
Thank you. I'll do a roll call vote. Commissioner Guillermo,
Yes.
Commissioner Chow,
Yes.
and Commissioner Chung.
Yes.
All right, thank you very much.
Thank you, everyone. We'll add these contracts to the consent calendar.
Thanks, Ms. D'Antoni. Item 7 is request for approval of an amendment with the Regents of University of California to provide the City and Department of Public Health with expertise in epidemiology, surveillance, and clinical services, data modeling, and public communications.
Before this is Michelle, before this starts, and I'll turn it over to Dr. Darpan to, I don't pronounce his name wrong, to speak to this. I just wanted to explain why this is on a health commission memo, but it's an amendment of existing services. And that's because you haven't seen this before. And the reason you haven't seen this before is this is an emergency contract specifically created because of COVID and for COVID response. And that is why you're seeing it in this format today. And with that, I'll just turn it over to representative.
Who's here for this contract? Item 7, the UC contract.
It was Dr. Darpan Sachdev.
I'm not sure if there's anybody. There's some folks in the public comment line. If you are here for to present or talk about item 7, can you press star 3 to raise your hand? I can move you in the meeting. I don't have. Oh, here we go. Great. Wonderful. I apologize. I didn't. I can't recognize everyone on the phone, but we just got the. Great. And I've unmuted you.
Okay. Thank
Great.
you. Thanks. Hi, this is Darpan Sachdev. I'm a physician with disease prevention and control and led our contact tracing efforts in San Francisco, in which we partnered with UCSF in order to create, launch, and implement our contact tracing team. Over the course of the past year and a half, we reached over 30,000 people who were diagnosed with COVID, provided them resources to support their safe isolation, and also identified over 30,000 contacts who also needed support in terms of quarantine. And UCSF was a key partner in helping to raise that system and support the ongoing implementation of the work. I'm happy to take any other questions.
Great. Folks on the public comment line, if you'd like to make any comment on item 7, this contract, please press star 3. Star 3. I see no hands. Commissioner Guillermo, I've unmuted you in case you want to make any comments.
None for me. Thank you.
All right, thanks. Anyone else? Commissioners Chow or Chung?
My only question, because I actually don't have the paper right in front of me, is was this by bid? Because obviously UCSF is eminently qualified to do this work, and it's wonderful work they're doing. So it's not negative towards that. I just didn't know if this was an RFP or this was a amendment, because I don't have the original paper in.
It was an amendment based on my understanding. It
Yeah,
wasn't a bid.
this is an amendment to the original contract, and the contract is, the authority is emergency contract called 21.15 from a mayoral declaration, which grants us the authority to contract for necessary services on an emergency basis without doing a bidding process or a sole source approval process.
No, I think that's great. We probably couldn't find a more stellar team. Well, there may be several more, but it's one of the premier teams, I'm sure, in the United States. I wasn't sure why we marked that. We've never done business with UCSF.
Could you clarify that, Dr. Chow? I'm not sure if that was clear to the rest of us around what you're asking around.
Okay, where it says in the contract, have we ever done business with UCSF, it has 0 years. I remember reading that because that strikes me as, unless this is some sort of very special contract for which we've not done business, obviously for what, nearly 100 years, UCSF has had different contracts with us.
Yeah, I think the way that the contracts analysts fill this out is a literal interpretation of this particular contract.
Yeah, but
Wanna-
we have an amendment. We must have been doing business with them.
We've been doing, you're right. This contract, before this contract today, we had not been doing this contract. And so this contract started on March 1st, 2020. So yes, you're right. We could have added that, but for this contract, it started March 12th, 2020. And we have not had this particular contract prior.
Sure, I think the question usually, as you know, Michelle, is have we been working with this? And I'll accept that the analyst was much more literal and looked at it from the standpoint of this particular contract. But it was a small point.
It's a small point, but I actually think that's really important point because we have been talking about a lot of like the organizations that we work with is like been merging with some other organizations and they are like so huge now, you know, that, you know, like we have no choice but to really making sure that, you know, like they don't, they perform, you know, like what they are agreeing to do. So it's really based on businesses with the organizations and not each individual contracts. And I think that, you know, that's a really good question that Dr. Chow just asked, actually. So that's my 2 cents as well.
Thank you, commissioners. I'm sure Ms. Ruggles heard that, and hopefully contract staff can maybe be less literal in that. It's okay if I move to the public comment line? Okay,
Yes.
cool. Folks on the line, if you'd like to make comment on item 7, please press *3 again. Do you have any? All right, I did that already. I apologize. So I believe we're now at a place where you all could consider a motion.
So I would move to approve the amendment to the Regents of the University of California under item 7 for approval, for recommendation to the commission for approval.
Commissioner Gilliam, are you?
I'll second.
Okay.
I wasn't sure if I was on mute or not.
Yeah, no,
But
great.
I'll second.
Great. So I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Guillermo,
Yes.
and Commissioner Chung.
Yes.
Thank you all very much. I believe we can move on to item 8, which is the health equity impact assessment for contracts. Dr. Bennett is going to start us off, and then there's a group of folks who are going to continue to present.
There we go. So you heard about this quite some time ago, so I apologies for the delay in you going from hearing about it as a theory to actually seeing it in practice. There were lots of COVID diversions and other reasons. But what I'm hoping is you recall that we are looking for a tool that you can use to understand how equity was considered in a program or contract, and be able to use that as a decision guide so that equity is considered each time you're making one of these decisions. The folks at CHEP, who were very, very busy already with COVID, very graciously agreed to put through 2 of their contracts through the process. So we did a training with them on how to use the tool. We had made refinements in it since the last time we had used it with a different group, and they have successfully used it. You should have paper forms or filled in PDF forms that are a little bit more long form answers to a set of basic questions. And we are going to hear a presentation of a little bit more abbreviated, hopefully. Hannah, please abbreviate. Hannah Fort. Abbreviated version of what you would see in that form. So this is your presentation of how equity was considered. We would want to do either 1 to 3 slides, depending on the depth of the issue for a presentation that you were seeing on a different contract in the future. So hopefully after January or so, we can launch this as something you see on a regular basis with new contracts. I'm going to turn over the floor.
All right. Hi, good afternoon again. Hannah Yord with Community Health Equity and Promotion Branch. I'm going to try to share my screen. Please let me know if this works. Let's see here.
We see your screen.
See it? Okay, great. And then if I do that, does that advance? Yes. Woohoo. Okay, and that's full screen.
It's showing,
Yeah.
it is full screen, but it's showing the a slide and the next slide as well with notes.
Okay.
If it's possible,
Okay.
it's okay if we leave like this, but it's ideal to.
Yeah, of course. Let me try to do that again. This happened before. Okay. Do one more try. Screen 2. How is that?
Much better.
Okay, great. Sorry about that. I get used to Teams. So I'm going to present about 2 of the programs that are part of CHEP's contract with Glide, which is the one that the Commission approved last month. And let's see here. And also, I just wanted to let you know that Juliana De Pietro is on the line as well, and she's the Director of Harm Reduction Services at Glide. And Juliana and her team provided a lot of this information since they have the expertise. So the first program is the HCV testing and linkage program. And the relevant conditions and the existing inequity there is that Black and African Americans in San Francisco have a proportionate burden of hepatitis C cases. And so we have data from 2018 and 2019. That's the most recent data that we have, and that shows that approximately 1/4 of Hep C cases in San Francisco were among Black and African Americans, and that community makes up, 5% of the total population. And this program is serving people in the Tenderloin who are at a really high risk. So low-income folks, people experiencing homelessness, people who use drugs, with a focus on Black and African Americans. And then 10% of that neighborhood approximately are Black and African Americans. This shows the budget, which is about $297,000, and that is split up over Hep C testing, recruitment and or linkage, and then also educational groups and support groups. And this program really connects the people at the highest risk and that have the highest burden to low barrier Hep C testing, and then also curative treatment. And the greatest impact is felt among the people that live or reside in the Tenderloin. And then I'm going to just mention some of the equity strategies that Glide uses to ensure the program's success. So before this contract was developed, so it's been in place for a while, they participated in the NHEP CSF collective impact planning process. And that included a lot of community meetings, a lot of trainings of community navigators who our peers that assist in peer-driven interventions. And through this planning, Glide was really able to identify the scope of services for this program and get input from community members and people with lived experience. And then implementation includes ongoing assessment using a racial equity lens. And they have lots of different service modalities like on-site testing, street-based outreach, working in SROs, etc. Their partners include the partner organizations in NHEP CSF and then DPH, and we work together on priority setting, monitoring data, and then support. And then again, I just wanted to highlight this Community Navigator program that includes participants who have been cured of hepatitis C and are trained to do outreach themselves and work with community members. And they provide a lot of feedback and important information. Let me just see, how do you all want to do this? Do you want me to go through the whole presentation? I had a couple of more points for this program, and then do we want Glide to weigh in or do that at the end?
It's not that much information. I think since we're really talking about how this worked for you, it'd be good to just get the information out and then we can talk about how this was useful or not useful and what the experience of it was, because we're really evaluating the tool, not the contract per se.
Okay, perfect. Thank you, Ayana. So just wanted to let you know that to evaluate ongoing as well, they're going to continue to engage in best practices research and training for their staff and program administrators. And they intend to develop a community advisory board that is reflective of the people that they serve. And then that CAB can also hold them accountable to their commitment to advance racial equity. So now I'm going to move on to the second program, which is the opt-in program, which stands for Outreach, Prevention, and Treatment Integration. And that is for HIV and Hep C. So as you heard during the 2020 annual HIV STI update, rates of new diagnosis declined among men of all races and ethnicities in 2020 for various reasons. But Black and African Americans and Latino men continue to have the highest HIV rates. And also in 2020, Black and African Americans, people who use drugs and inject drugs, Latinx communities, trans women who have sex with men, and people experiencing homelessness have the lowest viral suppression rates, and they're especially low among people living with HIV who are homeless. It's about 20% compared to 71% of people who are not homeless. And opt-in is designed to reach the most marginalized populations, and Glide does recruitment, intensive case management, and also linkages to HIV treatment or referrals for PrEP services for people who test negative. And they focus in Tenderloin, Soma, and Mission, and especially working with Black and African Americans and Latinx. So Hep C and HIV testing are not funded under this contract, but the testing data serves as a proxy for the community served. So I did present the Hep C testing data for Glide. The HIV testing data showed that in 2019, Black and African American San Francisco's constituted approximately 56% of all program participants who were tested by Glide, and Latinx 16%. And all of that is in the longer form that you have. The budget for this program is $200,000, and it funds intensive case management, enhanced recruitment and linkage, and supply provision. And again, this program is really designed to meet the unique needs of Black and African Americans and Latinos, as well as trans and cisgender women, and then people experiencing homelessness and people who inject drugs. And impacts are most felt in the neighborhood served. So before this contract was developed, Glide also did a lot of community engagement citywide, both in mobile and street-based settings, because they wanted to assess the health inequities for people who would not traditionally seek services in our systems of care. And then they worked with partners to host community-based testing events and health fairs. And the idea was really to bring services to the community. And then this was so successful that Glide has sought out additional funding to sustain that. Their ongoing implementation, again, is the same assessment I mentioned before. And then the modalities are street-based as well, and at encampments, etc. And then for evaluation, it's the same as I mentioned before, so I don't need to go over that again, just highlighting it because it is so important. I will say that what the community engagement showed them, what Julianne and her team shared, is that they need to spend both time and resources in culturally humble service to the communities that they serve, so that they avoid perpetuating inequities and especially racial inequities, and that they've learned that the stigma around HIV infection is particularly, oh, what is wrong with my screen? My computer just went blank. Is particularly high among Black and African American and Latino communities. And so they focus on gentle and persistent community building. They really want to engage people and meet them where they're at instead of alienating them or burdening them. Through well-intentioned approaches, they're often informed by white-centered health practices. And so that is the end of my presentation. Should I just stop sharing and then open it up?
Yes, if you would. Hannah, I just do want to ask either you or the staff from Glide, I would really appreciate even more, talking about just the time you put in and what you noticed about filling it out. I know a lot of the information you already had, which is great. I don't think that's true of every program of ours, but I can tell there'd already been a lot of work put in. So if you could just do a few words about it, I want to be sure we talk about the added burden to staff.
Juliana, would you like to go first?
Thank you all. Thank you all for having me. My name is Juliana DePietro. I'm the Director of Harm Reduction Services at Glide. This process was made so much easier with our partnership with Hannah and other folks at CHEP. I really appreciated what Hannah and Katie already put into this assessment. I think from a personal and anecdotal space, I'm new to Glide. I'm new to partnering with the DPH in this way. And a lot of our contracts predate me by several years. And so in thinking about the equity lenses and impact assessments that were done when the contracts were implemented, I had very little information, and it was really wonderful to partner with our partners at CHEP around filling in those gaps. I think this is an important assessment to do. And while I have a lot of things on my plate, I'm willing and enthusiastic about putting in the time to complete it because of the importance, not only in reflecting on what was done when these contracts began, but also thinking about equity on an ongoing basis as we implement these contracts in new iterations, and how we think about adjusting based on community need and based on maybe what currently isn't working. So I would say any amount of time that it would take for me would be appropriate, not burdensome. I do think there may be some benefit in reframing some of the questions for contracts that are ongoing. Perhaps we are unique, but a lot of it seemed to be framed around the beginning of contracts being implemented, and perhaps thinking about if this is a regular assessment, ways to reshape and rethink about, what has worked within the past year or since the last assessment, and then what are your plans for ongoing evaluations and monitoring the changes you implement in order to achieve your racial equity goals and your other equity goals. And I think, yeah, absolutely. That's all I have to add. Thanks.
Thank you. Hannah?
Yes, thank you. Yeah, it was definitely a team effort. You know, we had internal conversations in CHEP first on how to do this assessment, and Nicole Trainer, my colleague who's also on this meeting, we did the training together, and that was helpful to just to learn about the background and then what was intended for each of the questions. And then we had a meeting with Glide and just ongoing conversations, because I do feel like it's so important to include our community partners from the beginning and do this as a collaboration, because we may have contract history and history around what our intention is for these programs. They have the expertise of implementing and working with their communities. So, you know, we did have a lot of the data available already. I think it would be more of a burden if we didn't. But that's not to say that that's not what's important or needed. So I think this is a really great pilot. And for us in CHEP, thinking about the RFP that will hopefully be implemented next July, it will be important to do this a lot sooner and have this be part of contract negotiation and planning. So yeah, I don't know if Nicole, if you wanted to add anything as well.
Sure. Yes. Can everyone hear me? Okay. Yeah. I think this is a really great assessment tool, and I'm glad that we actually had the opportunity to conduct this pilot. I'm appreciative of the two organizations who were willing to do this pilot with us this round. One of the things I would like to see in the assessment is embedding the change in social conditions. That hasn't been, we haven't evaluated that. And we do know from a public health lens that health outcomes get better when we have an impact on social conditions. And I think that's directly correlated with equity. So with our next round of contracts, I'm hoping that we could definitely implement that in the assessment. And that will really help us align our programs and the services we provide as well. So,
Thank you. I'll incorporate all of that feedback. And then I turn it over to you committee members on how this might be useful to you. You'll see a slightly different version from this and other feedback when it launches, I'm hoping in January, but this is the underlying intent and format.
And if I may go to the public comment line first. First on the line, if you'd like to make comment on item 8, please press *3 to raise your hand. *3. All right, no hand. And Commissioner Guillermo, I have unmuted you in case you would like to make a comment or ask a question.
Thanks. I'm not sure if I'm hamstrung or not by not being able to see the screen, but I was following along with the handout that was provided to us in advance. And from what I could tell, it's very helpful. And I know that it's, from my understanding, this isn't a final assessment tool, or there's still a little tweaks that are being made to it. Is that correct?
Yes.
Dr. Bennett said yes.
Yes, we're starting with one, and we'll have to make versions that apply to clearly multiple different kinds of circumstances.
Right.
But the underlying format, I think, is what we'll go forward with.
I appreciate this, and I appreciate the combination of both having the sort of the data and then the qualitative information about the programs and their impact together. So at this point, just want to appreciate the work that's gone into this and look forward to continuing assessments and reports.
Thanks, Commissioner. Any other questions, Commissioners Chow and Chong?
I just want to make a comment and thank you, Mark, for forwarding that form that you forwarded earlier today. And I think that was a really great form to have to fill out, and because it goes a little bit deeper into like making sure that we understand what the contract is and, and what the program actually does and the rationale behind funding it. And so I really appreciate that a lot. And also, Dr. Bennett, I don't know if you you know about a new tool that was launched on National Black HIV Awareness Day. It's the Racial Justice Index. It's a tool especially, you know, created for, you know, like this similar purpose. So like if you don't, you know, I'd be happy to share the information with you as well. I think that, you know, you might find that very helpful as well. Of course, you know, what you have done has already been really phenomenal, and I really thank you for that.
We can always be better. Send me anything. I appreciate it.
Um,
Oh.
I had some questions, just trying to frame, Dr. Bennett. I mean, this is all great work. I'm trying to frame because you're trying to make it useful for us. How would this intersect with the contracts reporting? Are we talking about new contracts? Are we talking about the renewal of contracts? I guess I should start with that question.
Yeah. Ideally, it will be both eventually. I think we are going to start with new contracts. It's a little easier for people to produce the things we'd be looking for in the process of writing a new contract. For ongoing contracts, I think over time, the bar would be in fact be higher because you would want to say, how did you improve equity with what you already did? And how do you plan to do better in the future? That's kind of a high bar to ask now if people hadn't been thinking that way as they went into the contract. So I think it'll have to be phased in to be reasonable for people to be able to do, but definitely new contracts at first.
Okay, so I think the comments then made by staff earlier from Glide in terms of adding experience and the evaluation would be appropriate for the older contract, as you pointed out, and for the new contract. So obviously, the addition of the socioeconomic factors that was mentioned today also seems to be very important. And a little, so technically, would this be an added report or it would be merged in with all the very small print we have from from the contracts, or how are you envisioning that we would then get this as part of the evaluation of the contracts?
I envision you'd get that form, perhaps a little bit more compact, but the form that you did get for each of those contracts, Michelle and I can talk about whether or not it can be integrated. What I talked to Jenny Louie about is having this be useful as a way to start to input data to be able to categorize and track contracts, what populations are they meant to serve and things like that. So it may look a little bit different so that we can do that data entry. But what you have should be very close to what you end up with as a report for a contract. And I especially like the part about that was suggested about having people state explicit goals. I think that will be a push for some people to get really concrete, but we do have to get there.
Yeah, it would seem that this could also be where we've been trying, as Commissioner Chung knows, to try to get outcomes. And therefore, on the older contracts and the renewal of contracts, this might be the instrument to try to do that. I think it's also the instrument to help answer the age-old problem at the moment of what is cultural and linguistic competence, because this is probably one of the best answers I've seen in these years in trying to do that, aside from the one-liner that we constantly get that all the contractors will hold to our guidelines, and I'm not sure what our guidelines are anymore. I think this actually begins to really put meat on that framework. So I also commend you for this very hard work, and I think it's important though to try to streamline. I thought the bullet points, rather than seeing the entire document, in my mind, would be easier, providing the bullet points were not just using a stock phrase. but gave some specificity to that contract. Because I think your slides did capture, in my mind, the key issues, talking about who the population was, what the disparities are, what we're intending to try to do. And then it kind of ends up with the resources, and they seem to read the same on both sides. I think some specificity about where we're going to get, newspaper workers to go out there and hand out papers or whatever it is, would give us a little more concept as to what the contract's really going to do, and that's going to be helpful in general for us too. So thank you, Dr. Bennett, for even trying to pursue this work and moving the equity lens to health disparities. I really think that that goes beyond what I'm sure the city was at first looking at in terms of equity, and I think it's exactly what this department should be doing. Thank you very much.
My goal is to get past talking, so we're going to get past talking. I will say, though, I think there is a role for the commission in raising that bar each time. So I don't think people across the board have inputted the kind of outcome rigor and tracking that you would need to be able to say, I actually impacted this racial disparity. We just haven't been that rigorous in some of our contracting and programming, but I would hope that over time having to report and then being asked for more and more data and being actually challenged to say, well, but you were supposed to see Black people. Did you see Black people? So it was supposed to, in fact, see what was it like before? When do you think it's going to get better? So really pushing us towards that line, I think is going to be it's going to be the work of years. And I think it's really going to be on the commission to track that progression of the department as a whole.
I believe Ms. Ruggles has a comment as well, if that's okay, Commissioner Chung. Okay, great. Ms. Ruggles, you go.
Yeah, hey, thanks. Just being on this contracts end, I think this is great. And it does starts to put back into place what used to be, as you mentioned, the cultural competency and linguistic competency line that was in the report. Ayana, so this will be great. You'll have a tool again. I think Ayana and I'll talk about it. I think it'll be a separate tool. And one of the challenges that we'll have to monitor as we test this out in the implementation is how well it works and how well it aligns to have this tool presented at the same time as a contract. It makes perfect sense. We'll just have to see what the lift is as it's getting going for the program side to prepare this and have it align with the contract approval side. So that will be the goal, of course. And the other thing we may want to look at is incorporating this into an RFP process. So then at the beginning, when we do an RFP, then you'll get a baseline presentation of what's desired out of a solicitation. And hopefully in that process too, the system of care program side can build in new performance objectives that really get at this, that can then be added to what's currently out there. And that's a task also, to get ahead of the program performance objectives that get put into the contracts annually. So I just wanted to add that consideration.
Thanks, Ms. Ruggles. Any other comments, commissioners or anyone? All right, is it okay, Commissioner Chung, if we move on to the next item? Okay, cool. Thank you, everyone, all the presenters. Item 9 is emerging issues. Any comments from commissioners? A person on the line, if you'd like to make a comment on this, please press *3. All right, I seeing no hand and hearing no comments, we can move to item 10, which is general public comment. Person on the line, if you'd like to make comment about something that's not on the agenda, you can do it at this time. Please press *3. *3. All right, no hand. So you all are now at a consideration for adjournment.
I'd move for adjournment.
I'll second.
Great. Commissioner Guillermo, I will start with you for the roll call vote.
Yes.
Commissioner Chow
Yes.
and Commissioner Chung.
Yes, and thank you, everybody, and see you back at 4.
Have a lovely day, everyone. Thanks.
Bye-bye.
Bye-bye.
Bye-bye.